Lavage of the lacrimal ducts has been a diagnostic and therapeutic procedure since 1910. In the intervening 100 years, very little has changed to the basic technique or instrumentation. Syringing tear ducts is one of the first procedures we learn as ophthalmic trainees, and it is also one of the first we learn to delegate to nursing staff. This is because we find the exercise time-consuming, inconvenient, but generally little can go wrong. I've always found the technique flawed, and these clips show why. Once the cannula is positioned within the tear duct, it is then necessary to re-grasp the syringe in order to inject the saline. In so doing, the cannula can become misaligned or can accidentally be completely removed from the tear duct. This is one of our senior nurses as she routinely syringes a duct, and what I want to illustrate here is the way in which she has to reposition her hands on the syringe in order to inject the saline. And this is the other eye, and again it's apparent the general procedure is awkward in that, having placed the cannula, she then has to change hands in order to inject the saline, and the whole procedure is remarkably inefficient. There are many automatic infusion devices on the market for IV or gastric and so on. These are expensive and simply don't deliver sufficient volume or pressure which is appropriate to the lacrimal apparatus. In our clinic, we've developed an automated infusion device which addresses the problem of cannula instability. A foot switch activates a worm drive mechanism, and this pushes in the plunger on a 5 ml syringe, delivering saline in appropriate volume and pressure. When the syringe is empty, a trip switch reverses the current and the plunger device returns to the starting position. Syringe, tubing and cannula are then replaced with a new set for another patient. The tubing is from the standard IV infusion set. The drive mechanism is securely housed in a waterproof cover. I use a standard lacrimal cannula fitted to an extension handle, which I used to use for Simcoe cannulae when I first started extra caps about 20 years ago. With this device, it is no longer necessary to reposition one's hands in order to inject the saline. The cannula is inserted into the tear duct and the anatomy defined by careful tactile navigation. Once in position, infusion is activated and there is no suggestion of any loss of position or instability at the cannula tip. In this case, the cannulae are patent, but the sac is obstructed. 2010 marks the centenary year of lacrimal irrigation. Isn't it about time we made the procedure a little more user-friendly? This device has many other uses. This is an Aussie meat pie, and it's just been removed from the oven ready for lunch. Now, if one activates the foot switch and fills the syringe with a sauce of your choice, the meat pie can be brought to life with a simple application of your sauce in an artistic way. Now, there is a learning curve to this, and practice will be required. Having decorated the pie, there's just one final move, and what would have been a very boring lunch is converted into a celebration.